Listen, this morning was so awesome, everybody. And I'm not going to officially kick it off yet because I know that some more people are coming back in. But this morning was so awesome, and what I thought was awesome was to hear, other physicians beginning to speak out about, I know what are all of our concerns, And I just like to say that at this critical point in time, there are just so many moving parts going on, be it what's going on at the federal level, what's going on at the state level. And I appreciate Gene giving me the moderation, which is why I'm going to start now, because I want to grab 5 minutes from what's going to be fantastic presentations from Dr. Troutt and Dr. Newton. But if you look at what qualifying conditions are all about in Florida, I think the key is, why do we have 850,000 patients in Florida, right, compared to, I don't know, what's Ohio have at this point, Duffy? They've topped over 100, I think, and I'm not sure, 18,000 or something in Georgia, whatever it may be. Renee told me 19,000. 850,000 here in Florida, right? But we've kind of peaked. And I think everybody knows that really the program hasn't been growing. When Ron talks about having 1 million patients by election day, that would be awesome. But I think that's optimistic and not necessarily based upon what we're seeing. If you follow the OMU updates, you'll see that actually there was a drop of 2,600 patients in a couple of the updates of a couple weeks ago. But I'd love to see the program grow. But why do we even have 850,000 patients at this point? And, this segment is talking about qualifying conditions. And I know these guys are going to present, some cases. And I want to leave some time for questions, after that, because that's what doctors want to know. We want to know how the best means that we have to take care of our patients. But when you talk about qualifying conditions, early on, Duffy, you'll love this. I actually put together a whole talk about qualifying conditions. And I have a Q1 through Q5 qualifying condition talk that I've always used. And this is since day one in my clinic. When I saw a patient who had ulcerative colitis, okay, which isn't included, but yet Crohn's disease is. So I'm sitting there saying on day 2 in the office, I'm saying, what is going on here? Who wrote this? Well, it was obviously written by lawyers and legislators, not doctors. And my joke since that time has always been that the Crohn's disease lobbyists, and where's Ron when you need him? The Crohn's disease lobbyists had more potency than the ulcerative colitis guy. I mean, how else could that happen? They're the exact same condition. It's just different, obviously areas of the intestinal tract. So to me, I early figured out that as a physician, my role in this entire process was to be the gatekeeper for people that were coming in that wanted to use cannabis as medicine. And, that's Tommy Chong, not me, that it's all medicine. But what you find is that as you take care of patients, and we're in our 8th year in the clinic now, so I can't believe we opened up in January of 17. So here we are, and we've seen, obviously, countless patients, and you guys have heard me talk before. And listen, I appreciate Gene letting me have my 5 minutes because, these guys are going to give presentations, and the presentations we've heard so far have been awesome. And I think the most important thing I've heard today is that Dr. Block has chapters now in medical texts. We're 10 years down, from really seeing the impact of that, I think. But, that's the next step. But here's the point. Q1 through 5 qualifying conditions, okay? How can we use that? Q1 qualifiers, they have things that none of us want to have. That's cancer, that's MS, that's Parkinson's. We can all rattle off the 12 qualifying conditions. Chronic pain, we all know, has always had the asterisk next to it. I believe still does, which means that chronic pain has to be coming from one of the other qualifying conditions not currently active. We all know how idiotic that was. But Q1 qualifiers are easy, okay? And putting them in is no big deal. Not for us, but for them, because they all have debilitating conditions. Type 2 qualifiers, who are they? That's your ulcerative colitis patient. That's your patient who goes and gets an essential tremor diagnosis. They may even go to the Cleveland Clinic and have a stimulator put into their brain where they can dial it up, right? But no one's called them a Parkinson's patient, so they weren't supposed to qualify for the Florida program. So Q2 qualifiers have conditions so close to the ones that you shake your head and you say, how can that may not be included, and there's so many of those, but those are the two most obvious would be your ulcerative colitis patient and your tremor patient. Who are Q3 qualifiers? Q3 qualifiers are patients that come in with medical records, okay, that maybe have been to more doctors you could shake a stick at. These are your chronic mono, chronic Lyme disease patients, your fibromyalgia patients who have been put into the wasteland of care through the years. People that have had 3 failed back surgeries, right, and are coming out of pain management. They come in with records, okay, but they don't necessarily fit into one of Florida's boxes, right? And that's where Section K comes into play. Similar, likewise, or is comparable. If you've had 3 failed back surgeries and you can't even bend over to pick up your Sunday morning newspaper, okay, then no one's going to tell me that patient doesn't suffer from anxiety and depression, okay? So I don't need to send that patient who comes in with all those records out for a psychiatric evaluation. As an emergency physician, I'll make my own diagnosis, thank you, okay? So to me, I've assumed that patient's coming in for what we're all looking for, to feel the best we can in the safest way we can and to be legal in doing so. They set the rules up, not me. They wrote the law, not us. So we're not the policemen for the system. We're the advocates for our patients, right? And it's easy when they come in with medical records. Dr. Cummins, my dear colleague there, came over to my office, and it was awesome to have her. 3 years ago now, Lori, or something like that? She requires medical records in her office for every new patient that she sees. I've never required medical records in my office. I like when patients have them, but if they don't have them, I'm still going to put them in the system because that's what I do. We're advocates for our patients for safety. So 3s are easy. They come in with medical records. Who are the 4s? 4s come in because they're cannabis consumers in general already. They just want safe, legal access. They can be 30 years old. They can be on Adderall or Vyvanse for ADHD. They've gotten off them already, but they're cannabis consumers. Or their parents, when they were 17 or 18, sent them into, and listen, the amount of anxiety and depression that we see in young people these days is unbelievable. So the point is a lot of these kids get thrown on Ativan or Xanax and they want off. They want off. They don't want to continue with it. They haven't seen a doctor for a number of years, so they have no medical records at all. They just want safe, legal access to something that they're using already medicinally, right? So Q4 qualifiers, you have to become an advocate for them. They don't have medical records, right? And I'm not going to send them out for a false evaluation, okay? And that's why I personally fear Schedule 3, because I don't want insurance companies coming into my world. If I'm going to put a diagnosis of insomnia or anxiety on that young, healthy 30-year-old, I'm doing it for a reason, for safety. Because I want what they want. I don't want them running into fentanyl on the black market, right? I don't want them worrying if it's a sativa or an indica or mold or fungi or being illegal, which is a source of innate anxiety for everybody. So my point is Q4s are Q4s. Who are the Q5s? Q5s just want to take cannabinoids for wellness. You have to remember when we started 8 years ago, there were no Delta-8 products out there. We didn't know much about CBD. The other significant thing I heard yesterday was that there's another category of cannabis, type 4 cannabis, CBG now, right? High in CBG. That's awesome. So we're going to see so many changes in cannabis world, but I just wanted to point that out as my purpose of being up here is to continue with that process that we all want to do, is to practice with honor, practice with integrity, practice with education, right? And advocate for our patients, period. And that is the beauty of the Florida law as compared with other states. So if there's any one thing that we need to preserve in this state, it's that ability to continue to care for all of our patients, no matter what their desires are that they come into us for, because that's what they deserve. It's such an honor today, and I did grab a little bit of time, and I want to first off laud Trulieve for their sponsorship of this event. They're here at every event, and if they weren't here, then we wouldn't be having an event. So I surely want to, give that shout out. Gene Jones, of course, always final man standing. We used to have a couple, 3 different cannabis conferences a year. Now we have one, and Gene takes risks in putting it on. And I just want to give one more shout out to the Florida Medical Cannabis Group. You know, not my official baby, but kind of my unofficial baby. It's a joy to get together with physicians on Wednesdays, every second or third or fourth when we need to. It's a warm blanket for all of us. So make sure you see Charles and get involved with the group. Who's going first? Terel? Listen, I've known Terel Newton for a while. He's always been a mentor to me as somebody who brings just the highest level of intelligence and science to our practice. Comes out of the pain management and anesthesia world, of course, and just brings an unbelievable legitimacy to our practice, and it's always so great to hear his views.
Yeah, thank you very much. I appreciate that. And hoping that this presentation today I can bridge the gap between what I covered yesterday, which was the endocannabinoid system, and the next session, which is on dosing. And so I'm actually going to start out with some of the tougher cases today and go into pediatric palliative care to show that how can we recommend cannabis safely to our pediatric patients, and how can we document severity, because that's very important when we're talking about medical necessity. Let's get a quick review of yesterday. I covered the discovery of THC by Dr. Raphael Mechoulam, which eventually led to the search for the endocannabinoid system and the receptors where THC where it binds to. And then that eventually led to discovery of anandamide 2-AG, as well as the endocannabinoid associated enzymes. So how do we metabolize cannabis in our bodies? So this is an important topic, mainly because we're dealing with this opioid epidemic, which has come in 3 waves. The first of those 3 waves being prescription medications, the second one being heroin around 2010, and the third one, which we're currently in, is synthetic opioids such as fentanyl. And the majority of that fentanyl is not prescription-based fentanyl. That's fentanyl that's brought into the United States in the form of carfentanil, which is 100 times stronger than fentanyl, or fentanyl, which is 100 times stronger than morphine. So pain is one of the most important qualified conditions. It's the #1 qualified condition for Florida, as well as our neighboring state in Georgia. And I just put this up here as a reference because some physicians are licensed to practice in both and actually do recommendations in Georgia as well as Florida. And in Georgia, they have 17 qualified conditions, several of which cause pain, which I put in bold here: epidermolysis bullosa, peripheral neuropathy, a lot of patients in hospice care, intractable pain. You can even say PTSD, because PTSD is an emotional experience and often comes along with pain. Of course, cancer, multiple sclerosis, Crohn's, and sickle cell disease. There's even been more recent research that shows that patients being treated with cannabis for sickle cell disease have a reduction in hospital admissions and hospital and ER visits. And here we have our 13 qualified conditions, which we're all familiar with here. So these first couple of cases are pediatric patients that were treated with a 1-to-1 CBD THC product. And you'll see in the study they named it FM. That's just the name after the company that produced the product. So the first patient is a 4-year-old boy with severe neurologic impairment, uncontrolled epilepsy. He was experiencing chronic pain and irritability. And the patients in the study were started out at 0.1 milligram per kilogram per day. And then titrated every 7 days. They added an additional 0.1 milligram per kilogram per day. And these were divided between 2 and 3 times daily. And so what they found was that there was a significant reduction in the seizures as well as the chronic pain. And they tracked something called the PEDSQL. And what that is, it's a score to look at family quality of life and how the child's condition is impacting the entire family. So I think that would be a good resource to use if you're doing recommendations for pediatric patients where you want to document severity. Not just severity based on the pain scale, which at this child's age you could use a toddler scale. However, given the severe neurologic conditions, some of the pain scales may not apply in this particular situation, so you can use a family quality of life scale as an alternative. This next patient was an 18-year-old boy with lissencephaly and drug-resistant epilepsy. Lissencephaly is actually a condition where the gyri and sulci of the brain look smoothed out, and it's a rare developmental disorder. And so this patient experienced an 80% reduction in pain and decreased seizure frequency from 8.7 per day to 2.3 per day. Again, on a one-to-one product that was titrated 0.1 milligram per kilogram per day, where they increased it by additional 0.1 milligram per kilogram per day every week. And this next case is a 19-year-old boy with coenzyme Q10 deficiency, had severe neurologic impairment, experienced chronic pain and frequent seizures, had it at the 4 to 5 week mark, had a significant reduction in seizure frequency, and it eliminated the need for any additional analgesic treatment. So when we look at chronic pain, what areas are we impacting on the pain pathway? So pain can start peripherally. And one of the interesting things about medical cannabis is that regardless of this origin, the pain is going to be blocked here because there's connections with interneurons. And then up here in the thalamus, before it travels by third-order neurons to the somatosensory cortex, the emotional centers of the brain, and the frontal cortex for planning and avoiding those pain stimuli in the future. So whether you're dealing in diagnosing a patient with a musculoskeletal pain, so let's say they have osteogenesis imperfecta, for example, is a condition where children may have chronic bone fractures, or you're talking about a hereditary condition associated with neuropathic pain, or an arthritic condition, so like juvenile rheumatoid arthritis, you can successfully treat those patients for their pain as well as any other neurologic conditions that they may have running concurrently. And that's because we're just blocking the pathway. All right, so here's a couple of more cases getting into some increased complexity here. So this is a patient, 14-year-old patient with Rett syndrome, moderate cognitive dysfunction and seizures, was titrated on the 0.1 milligram per kilogram per day increase, and by the second week had some degree of reduction in seizures, had improved sleep, as well as increased relational ability, so increased communication for this 14-year-old. The overall family impact score remained relatively stable. So not much change there, but there was an increase in communication and increase in sleep. 17-year-old boy with severe psychomotor impairment, also had frequent seizures and high-intensity pain, titrated up to 0.6 milligram per kilogram per day, had significantly reduced pain intensity, reduced seizure frequency, and the family quality of life score improved across several domains. And then a 5-year-old with severe neurologic impairment, moderate pain. For this particular patient, they did not completely fill out all of the documents here in terms of how much the patient was taking, because the patient was on the medicine for a while and then taken off and then restarted back on the medication. But overall, there was an improvement in family quality of life. So how can we treat seizures and pain at the same time? And when we think of seizures, I have a couple of mnemonics for this. One is EEG, right? So we always get an EEG for seizure patients. And so for me in the treatment side, that first E is the endocannabinoid system. The second E is the entourage effect. So when we're combining CBD with beta-carotene, for example, which functions very similar to CBD, as well as beta-myrcene and lanolol. And then the G is the GABA. So when we increase GABA activity, it's an inhibitory neurotransmitter. That's one of the functions of how cannabis is helping patients. So we see this GABA receptor here. So EEG is the endocannabinoid system, the entourage effect, and inhibition through GABA. Now when we add treatment for pain, pain is going to function on those same pathways, but we're Also going to look at one of the most important receptors here for pain management, which is the vanilloid receptor. Okay, so we see it down here. This is the vanilloid receptor, also called the capsaicin receptor, where topical capsaicin works as well. So when we talk about the entourage effect for chronic pain, how do we know that this is helping our patients? How can we prove that there's an entourage effect? One reason that we can prove that there's an entourage effect is because these components individually have been shown to help with pain. So if we combine them, we can imagine that there'll be cumulative effects. So up here is the phytocannabinoids, including CBD, THC, CBG, and other cannabinoids, including the acidic cannabinoids. And then we have D-limonene, which has been shown to help with neuropathic pain, beta-myrcene, which has an analgesic effect as well, and then linalool, which is a local anesthetic as well as a sedative. So let's get into the adults here. So this is a 29-year-old male with Fabry disease, which is that's one of those liposomal storage diseases that we hear about in medical school. And so with this, we have a fat accumulation into the various tissues of the body. Patient experienced pain in the hands and the feet, abdominal pain, diarrhea, heat intolerance, and anhidrosis. And so this patient was started on a product here, THC 8%, CBD 12%. So this is a near one-to-one product. And the patient had improvement after 1 month, and that improvement was maintained after a year. Okay, so one thing that's important for our neuropathy patients is to look at how we can help them improve inflammation. And we want them to realize that the benefit may not occur after the first few doses. So when we're dealing with inflammation, it has to, the patient has to be very patient, and we have to make sure that they're able to get not only the cannabinoids, but terpenes. And this is something that's shown in the certificate of lab analyses as well. This is another case, a 51-year-old female presented with diffuse pain, sleep disorder, and she was diagnosed with fibromyalgia. She was started on a cannabis sativa 6-CH 5 drops sublingual thrice daily. So what this means here, this is actually a homeopathic preparation. When we talk about homeopathic preparations, we're dealing with very dilute substances. So for this one, 6H means it was diluted 1 to 10, 6 times by 1 to 10. So we're talking about a product that if it started out as the initial material being 100 milligram per ml, what she took was 0.001 milligram per ml, being diluted 1 to 10, 6 times. And so even after 2 months, the patient returned asymptomatic with tender points, visual analog scale of 0. So if we're starting with severe pain, which on a 0 to 10 analog scale is going to be at least 7 out of 10, and now 2 months later, this patient has 0 out of 10 pain. And she had a well-being score where well-being is 0 is low, 10 is the highest degree of well-being. Her well-being score was 9 out of 10. So we have this concept that I discussed yesterday, the deficiency of the endocannabinoids, which can lead to pain sensitivity. And we have several conditions, so migraines, where we have a patient that may interpret light, and that light stimulates pain. Also sounds can stimulate pain. Fibromyalgia as a nerve sensitivity syndrome, often diagnosed where enough pressure to blanch the fingernail is a pain stimuli for a fibromyalgia patient. When we compare fibromyalgia to neuropathy, with neuropathy we can see a light touch cause pain, and that's something called allodynia. But usually with fibromyalgia we see hyperalgesia. So you just touch them with a pressure response. But a light touch would indicate something is going a little bit, something is a little bit more than fibromyalgia is going on. And so that may need further investigation. And even with visceral pain such as IBS, and so this is irritable bowel syndrome. This is not inflammatory bowel syndrome. We're just talking about alternating diarrhea and constipation. If we look back to that previous patient, let me go back to this patient here. All right, so this is the patient with Fabry disease. They were experiencing some diarrhea. which at times you do get improvement in those symptoms as well, because 80% of our immune system is in the GI tract, and oftentimes that diarrhea is a response from our immune system to what we're eating. And so in this particular study, with patients with fibromyalgia that were started on cannabis, you'll see their pain scores went on a visual analog scale from 8 out of 10 to about 2.8 out of 10 with cannabis. And I just included this to remind us that we want to concurrently treat anxiety and PTSD. This month is PTSD Awareness Month. It's also Cancer Survivor Awareness Month, so it's a good time to recognize that while we're treating someone's pain, we can also treat the emotional experience that they're going through. With regard to the entourage effect, some of the best terpenes here: beta-myrcene, linalool, D-limonene, alpha and beta-pinene, especially if the patient is dealing with depression. So we have this endocannabinoid system, and as Dr. Block had mentioned earlier, that it's in all mammals. So I did want to put a feline case here. I don't like cats, I'm allergic to cats, but I want to just make sure that we're continuing our learning and evolution to the next stage here. So this is a 10-year-old mixed breed male cat presented with clinical signs related to chronic orthopedic pain. And so how did they diagnose that? So there's this feline musculoskeletal pain index that is used by veterinarians to measure the pain scale, and it's often based on activity. And so for this particular patient, they used the full spectrum cannabis oil. It was near 1-to-1, so it was 1.8 CBD, 0.8 THC, and was dosed at 0.5 milligram per kilogram based on CBD. The only thing I would say about this is that in general, I would recommend to try to base dosing off of THC because it's more potent. But regardless, the patient had a significant improvement without any major side effects. So the cat's pain score decreased by more than 50% based on this particular feline musculoskeletal pain index score.
I'm trying to think what the side effect would be. Maybe increased catnip response or something.
Yeah, yeah. They should have thrown some catnip for entourage effect there. So. And so, what other conditions are veterinarians recommending cannabis for dogs and cats? So, very similar to human patients. So, pain, but a little bit different behavioral problems. Our second most qualified condition is usually anxiety, PTSD, or something related to mental health. And there were some that were recommended cannabis for seizures, and some of the pets that were recommended cannabis for inflammatory conditions such as dermatitis. All right, and so I want to conclude with this interesting case here I found in the literature. And this was a 15-year-old male patient that presented to the ER with left leg weakness, altered mental status, and chest pain. He had been experiencing vague symptoms of fatigue and weakness for about 1 month. Past medical history included cannabis use disorder, mild depression, and a remote history of seizures. Workup revealed an elevated D-dimer. It's positive for cannabinoids. The brain MRI, EEG, and CSF analysis were unremarkable. And so catatonia was suspected, and the patient was given something called a lorazepam challenge. So what this is given a low to moderate dose benzodiazepine, and you get a paradoxical response in that the patient will become more alert. And so this patient experienced complete resolution of the symptoms after being given that lorazepam challenge. Further history revealed that there was frequent marijuana use, including the vaping of THCO acetate. And so when we look at the mechanism of how the catatonia occurred, so this is an example of overactivation of the endocannabinoid system where there's excessive stimulation of the CB1 receptor. And because there's the presence of the CB1 receptor in the frontal lobe, in the basal ganglia, the patient had problems with movement, and also in the hippocampus, which caused problems in memory and concentration. And this is through, additionally, as I mentioned before, the GABA receptor, so GABA inhibition. In addition to that, there's some dopaminergic and glutaminergic dysregulation. But a big part of this is going to be the effects on GABA. And so what is THCO acetate? So this is one of the synthetic cannabinoids that is sometimes found in hemp products.
Illegal in Florida.
It's more potent than THC. Depend on the patient's receptor population. It could be 3 times or more potent compared to cannabis, compared to Delta-9 THC. And not only that, it also has a delayed onset as well as a prolonged duration. So THCO's effects can last longer due to higher potency, and it's unknown as far as the metabolism of this product. So it's almost a prodrug, so there's probably some active metabolites. And this structure here is just for comparison purposes. So this is the THCO acetate here, and this is Delta-9 THC, and this is a THCA for comparison. And you see this oxygen group and carbon double bound the oxygen here. So that's the main difference here, is that you have that double bond there, that acetyl group.
And that is a product that is illegal in Florida. It's a synthetically created product that's not allowed to be on the shelves. You will see it, and people will definitely get it over the internet. So I've had patients bring in THCO into my office, but it's illegal in Florida.
And those are the type of products that should go through double-blind, placebo-controlled studies before they're allowed to be marketed.
Of course.
So in conclusion, cannabis can be safely recommended to patients that's dealing with seizures and chronic pain. And this particular patient cohort that I reviewed here, they tend to do better with one-to-one. You know, CBD is a great product, but the advantage of the entourage effect allows them to benefit with very low doses of THC. Cannabis is, I would say, best given when we consider that there's an entourage effect, so that we're taking advantage of the certificate of lab analysis, which we can review. And when we incorporate other medicines such as beta-carotene, beta-myrcene, linalool, that's very good for patients dealing with chronic pain, also with seizures. We want to try to avoid side effects, so we want to give some time for the patient to accumulate to a steady state. And so in that study, most of the patients were titrated. After a 7-day period, they were increased to the next dose of 0.1 milligram per kilogram per day. When we look at these dramatic responses, we often see that patients dealing with fibromyalgia, migraines, and IBS often benefit from very low doses. In that one particular study, saw a patient benefiting from even a homeopathic dose. When we're dealing with patients with more severe situations such as neuropathy, which this would also include complex regional pain syndrome as well, we may need to be a little bit more aggressive as far as titrating for those patients when we get to adult use. When I'm talking about adult patients. And then lastly, we see that the endocannabinoid system is present also in pets as well. So, you know, in consideration of the pet parents in here, that's also a product that we may have one day here in Florida. So hopefully you stop the Trulieve if you have a pet that's needing a product. They actually have a product there in Arizona in adult use. And I'm not sure how Dr. Troutt could probably talk a little bit about the feedback that they've gotten. And I think it's a product that you can actually, can they order that here for pets?
The CBD
Yeah.
dominant products
Yeah.
have less than 0.3% THC.
Yeah.
They can for sure.
Okay, so that is actually a product that will be available. So if there's any pet parents here, that would fall under the hemp category. So they could order that from Trulieve.
Not from Trulieve. We don't ship anything across state lines.
Oh, yeah. No, I think it's important also, of course, specific product type of recommendations and a CME type of thing. We want to make sure that I don't know we're objective, but I know he'd be happy with me for saying that. No, excellent. One of the things that I want to ask you, Terel, specifically, in that 17-year-old patient case, and I know Dr. Berger is going to bring this up.
Can you use the microphone, please? That's laying there on the table. Could you use the microphone on the table?
When David gets into the pediatric
They cannot hear you online. They cannot hear you. Just use that microphone there, please. Thank you.
Yep. So, because the doses are interesting. If you look at that 17-year-old patient, if you're doing a 1-to-1 and you're doing a milligram per kilogram per day, then your THC dose, obviously with a 70, kilogram 17-year-old or so, listen, that's going to be 70 milligrams of THC a day. Dr. Berger will tell you in the pediatric population that can often be tolerated absolutely appropriately, and I'm not going to steal from you, but once again, it's interesting when you get into the THC doses, on some of these milligram per kilogram per day, type of cases to that extent. Listen, we're going to have absolutely time for questions afterwards, which is awesome, and I know I have some more questions to that extent.
Yeah, and there was Dr. Troutt had gone over this a little bit, that there's a protective effect with CBD as well, so you may see patients tolerate higher doses with THC when CBD is also present. So this is a near one-to-one product.
Interesting, and I want to give a shout out to Paige Setson, one of the Trulieve reps. She came up to me very excitedly talking about some stuff that she heard at the consortium, which actually speaks a little bit to the opposite of the CBD effect, with THC. So the point is there's so much going on that's changing right now about our understanding, and why getting cannabis off of Schedule 1 into 3 is so critical, so we can really get the answers to the questions that we want, of course. Anyway, we'll get you back up for more answers. Listen, our next speaker, and Dr. Trout's been up already, but I want to speak. I want to speak personally to my my developed respect for Dr. Troutt. He came a little bit later into the Florida cannabis world than some of us that have been here, but I've gained a significant amount of respect for his knowledge base and his passion towards really wanting what we all want, which is the highest quality of medicine for our patients. And really coming from the naturopathic background that he does, and I think Dr. Block spoke to this well, I think he does really bring a different level of training and experience, and I think a lot of us allopathic and osteopathic physicians, really don't get some of that training. So it's really been a joy to have been more acquainted with Duffy. I was honored to have him come through my office a couple weeks ago on his way back up from the CanMed, and it was just such a joy to be able to show him what we have going on here in Florida. One last comment, and I see you're back in the room. I was so struck by your comment about doctor education in our space. And I've called this out on this stage in the past, and I'm going to call it out again. That's why we're here, is to educate those patients. And I don't care if they're Doobie 1, never done, that need education, go slow and start low and go slow. Or if you're Willie Nelson, Doobie 4, who's used a THC-based product for years. They don't know often about CBD and the other cannabinoids, but it's still a joy to teach them. And I tell each and every one of those, those old timers, so to speak, that listen, the cannabinoid world of 2024 is different than that 1969 image. And there's different cannabinoids and different ways to use them. Sometimes they poo-poo you, but they come back in 210 days and they thank you. So I think the way that you take care of those patients that perhaps the state doesn't necessarily want us to put into the program is make sure that we educate each and every one of them to the extent of making them a better and safer cannabis consumer. And that's always been our role in this space, always. And, I'm just, like I said, hopeful that we'll be able to continue to do that as we go forward. But I want to bring Dr. Troutt up. I know he's going to have some fantastic insights for all of us.
Thank you so much, Barry.
Absolutely.
Thank you. All right. Thank you so much. And Barry gave me a great segue starting off about talking about Crohn's disease and ulcerative colitis, because we're going to talk about inflammatory bowel diseases as qualifying conditions. And again, as a naturopath, the GI tract or the gut is our bread and butter. And if we have a time at the end, I've got a couple slides on cannabis hyperemesis syndrome and a case study as well surrounding it that is a bit concerning for me. So, incidence of inflammatory bowel disease at the turn of the 21st century, IBD was recognized as a global disease. The incidence accelerates in industrialized societies that are becoming westernized. So again, this is an environmental disease, whether we're talking about pesticides, pollution, dietary concerns. These are definitely contributing to the incidence of inflammatory bowel disease. Although it's stabilizing in Western countries, the worldwide burden remains as high as 0.3%, and in 2015 in the United States, it was estimated at 1.3%, 3.1 million people with a diagnosis of inflammatory bowel disease. Crohn's disease versus ulcerative colitis, they're actually difficult to diagnose between each other. Crohn's disease inflammation involves the entire tract, all three layers of the bowel. With ulcerative colitis, inflammation usually begins in the rectum and is confined to the mucosal layer of the colon. Causes disruption of the mucosal system that increases immune response to the microbiota, and changes in the gut flora of the epithelial function that initiates a pathologic immune response in the normal mucosa. Greatest symptoms we see with individuals, diarrhea, abdominal pain, rectal bleeding, weight loss, mainly characterized by inflammation. So, and you brought up a really good point about Crohn's disease being accepted in Florida and most states that allow inflammatory bowel disease, Crohn's disease as a qualifying condition, but not ulcerative colitis. The reason being, or that's given, is that there is not as many studies out there on ulcerative colitis versus Crohn's disease. But I imagine the states that do allow Crohn's disease, we get a lot more diagnoses of Crohn's disease in those states versus ulcerative colitis to get people those cards. As far as that diagnosis, abdominal pain with Crohn's disease, usually in that right lower quadrant. Ulcerative colitis, cramps, more often in that lower left quadrant. Diarrhea, very frequent in both. Constipation can alternate ulcerative colitis. Blood in the stool, always present with ulcerative colitis and can be an indication of the severity of that disease. Abdominal masses, lower right quadrant, again inflamed ileum with Crohn's disease, lower left quadrant with ulcerative colitis. Hyposomia, loss of smell, interesting. That's one I didn't catch until I read this. Occasional with Crohn's disease. Malnutrition frequent with Crohn's disease. Obstructive symptoms frequent with Crohn's disease. And then perineal disease or fistulas up to 30% in Crohn's disease. Laboratory anomalies, protein CRP, very frequent in Crohn's disease, anemia frequent in Crohn's disease, and then your antibodies are hallmarks of the ulcerative colitis. Ileus, occasional Crohn's disease, hepatitis, occasional in ulcerative colitis because it's climbing up to the bile duct. We see smoking quite often as in epidemiology with it. Endoscopic appearance, rectal involvement, frequent with Crohn's disease, almost always in ulcerative colitis. We see that cornerstone cobblestone appearance, very frequent in Crohn's disease. Strictures, occasional Crohn's disease. Skip lesions are very common in Crohn's disease where it's continuous in ulcerative colitis. Mucosal edema, very frequent in ulcerative colitis. And then as far as our imaging is concerned, increased bowel wall is extensive in Crohn's disease, and mesenteric lymph nodes, frequent Crohn's disease, and fat wrapping as well of the mesenteric region. So our conventional medications for IBD, traditionally anti-inflammatory drugs, first line, immunosuppressive drugs, biologic, others, antibiotics, diarrheal, pain relievers, surgery. And just look at the side effects that we see for many of these medications: severe back pain, bladder pain, joint pain, muscle aches and pains, pains in the growing genitals, stomach cramps and pain, loss of appetite, nausea and vomiting, trouble sleeping. I think a lot of things that a lot of times we don't realize that many people are using cannabis just for the side effects of many of their pharmaceutical medications as well. And cannabis has a great potential to provide them relief of those symptoms and quality of life. So this endocannabinoid system regulates the GI function, food intake, cell proliferation, gastroprotection, secretion, ion transport, motility, pain and visceral sensation, epithelial integrity, gut microbiota. Our CB2 receptors are throughout the myenteric plexus. They're part of the epithelial barrier in the tight junctions, controlling those tight junctions as well. Our CB2 receptors are associated with the immune system on the other side of that epithelial barrier and all of the immune cell response. And again, this epithelial barrier is where our body, that's kind of the front line, right, of our protection from the outside world. And this endocannabinoid system is very active in this process. Gut-brain axis, very important, and probably this endocannabinoid system is one of the main contributing factors to the communication between our gut-brain axis. Bidirectional, nonlinear communication between the brain, the gut microbiome, involving multiple channels and feedback loops. Brain modulates the microbiome through alterations in the gut microbial environment. The gut microbiota communicates with the brain directly via signaling molecules or indirectly via gut-brain axis. Adult and pediatric patients with IBD demonstrate increased GI permeability, so allowing access to that outside world to get into the immune system, stimulating that immune response. Stress has been linked to deterioration of the intestinal barrier via gut-brain interactions. We know this is a very stressful world, and as you brought up earlier, people that are using cannabis just for those preventive purposes, stress reduction, can have a big impact on this. In preclinical models of stress response, activation of the corticotropic releasing factor and mast cell axis adversely affects the intestinal barrier, mucosal layer, composition, water and ion secretion, and intestinal permeability. In asymptomatic Crohn's disease patients, impaired intestinal permeability is found to precede clinical relapse by up to 1 year. A significant portion of first-degree relatives of patients with IBD have increased baseline small intestine permeability. So this brings up the question, which came first, chicken or egg? Is it the intestinal permeability that is allowing access to the immune system and stimulating the immune response and causing or precipitating inflammatory bowel disease, or is it the inflammatory bowel disease that is, again, precipitating the barrier concerns that we're seeing? Probably a little bit of both, but I would suggest that the leaky gut is a big part of that. And then we're starting to find out that our microbiome signatures and the microbiome of the GI tract is a huge part of this communication between our GI tract and also the health and involved in the permeability as well. Patients with IBD have significantly less phylogenetic biodiversity than healthy controls, and we're finding out that our industrialized microbiome has very low biodiversity and variability in it. Patients with CD have less diversity than patients with ulcerative colitis and healthy controls. Patient populations with CD and UC had significantly different taxonomic compositions from each other and healthy controls. In fact, different regions of the GI tract that are involved in Crohn's disease have different composition of the microbiome, and there's even suggestion that those are potentially even different diseases or different disease processes based on the microbiome that we're seeing and the infections that we're seeing associated with it. In Crohn's disease, patients' obligate anaerobes were significantly decreased, and facultative anaerobes were enriched, and the genus Streptococcus Burkholderia, acinobacteria were significantly enriched compared to healthy controls. And gut microbe and influence on the endocannabinoid system, very intrinsically linked. The endocannabinoid system links the gut to the brain and is affected by the gut microbiome. They interact via the hypothalamic pituitary adrenal axis, the vagus nerve, and systemic neurotransmitter hormonal regulation. Receptor sites on bacteria, Helicobacter, Escherichia coli, Pseudomonas respond to human neurotransmitters and hormones. and immune factors resulting in measurable changes in the microbiota composition and virulence, reinforcing the bidirectional aspect of the gut-brain microbiome axis. Microbiota manipulations with antibiotics is associated with a 2.5-fold decrease in total bacterial counts, and CBD expression has been shown to be upregulated in mice that have been associated or had antibiotics on board. Gut microbiomes influence endocannabinoid system tone, and lipopolysaccharide release during dysbiosis stimulates potent responses from the endocannabinoid system. And here's a couple research articles that have been published on the topic. Again, we need a lot more of these studies to really tease out the potential of cannabis and different types of cannabis medicines. But this one is looking at use patterns among patients with inflammatory bowel disease. It's a survey study. Prospective cohort survey study on 292 patients with IBD at the Brigham and Women's Hospital Crohn's and Colitis Center. 12.3% of surveyed patients were actively using cannabis. The majority of patients reported using cannabis for disease symptoms and believed it to be very helpful for relief of abdominal pain, nausea, and diarrhea. They saw the indications for use were younger users were more or younger people with IBD were more likely to use cannabis, and also people that had more severe symptoms associated with IBD were more likely to use cannabis. So these individuals had lower SIBDQ scores and were more likely to have chronic abdominal pain. 48.6% of the study population reported never having using cannabis. Among them, 51.7% said they would be interested once it became legal, the majority citing abdominal pain as a desired reason. And this brings up the point I was talking about earlier, is that there's a huge population of individuals out there that are untapped, that are still not using cannabis, and it's the legalities of it or the exposure that is keeping them from using cannabis. So we've got a lot of education to do to bring them into the fold, and some of these people are just the dyed in the wool. While it's illegal, they're not going to touch it no matter how much education that you do for them. So I think we've got a really big potential to increase our patient population as it becomes more acceptable, as it becomes legalized, as we get more studies to help change hearts and minds surrounding it. And obviously do some incredible work for the quality of life of a lot of individuals dealing with these disease processes. So findings suggest that patients with ulcerative colitis may also benefit from the cannabis use, although most states have only approved its use for Crohn's disease. And again, this was a discussion that they were having in the journal article itself about that topic. This is a study looking at palmitoyl ethylamide and cannabidiol to prevent inflammation. And the palmitoyl ethanolamide is a substance that is very closely related to our own endocannabinoids. It stimulates the TRPV receptors and the PPAR receptors as well. And they were looking at the hyperpermeability of the gut after they applied cannabidiol and the PEA. And what they found was, looking also at inflammatory markers, is that CBD prevented inflammation, decreased Claudin 5 mRNA in the human mucosa, and that was a significant result. They found that PEA and cannabidiol prevented an inflammation-induced fall of TRPV1 receptors and an increase in the PPAR transcription, and that was significant as well. And then they saw that, they use aspirin a lot to induce the permeability of the gut, which also tells us about the concerns around people that are taking high amounts of aspirin as well. But what they saw was that, and they're measuring lactose and mannitol, and these are standard tests for measuring the permeability of the gut, as well as seeing how much of those sugar breakdown products are seen in the bloodstream and gut. And what they found was that PEA or CBD reduced the amount of lactulose and mannitol getting into the bloodstream. So we're having a positive effect on decreasing the permeability of the GI tract. So their conclusion was that they've demonstrated for the first time in humans that PEA and CBD prevent increases in permeability in the inflamed gut and may do so through changes in aquaporin and tight junctions and receptor expression. This is an observational study looking specifically at Crohn's disease, 30 patients, and what they saw was 21 reported improved significantly after cannabis treatment. Indications for use were lack of a response to conventional therapies and intractable pain. All but one patient inhaled cannabis. The average dose was 1 to 3 joints per day. The average Harvey-Bradshaw index for disease severity improved from a 14 to a 7 in these individuals. The visual analog scale for quality of life increased from a 3.1 to a 7.3. The need for other medications was significantly reduced. Patients using steroids reduced from 26 to 4. Again, we all know the concerns surrounded with long-term steroid use, so this is a huge potential benefit to patients with IBD. 15 of the patients had 19 surgeries over a 9-year period prior to cannabis use. Only 2 patients had surgery in the 3 years post-cannabis use. And all patients stated that cannabis had a positive effect on disease activity. 9 patients measured no significant improvement and less than 4-point decreases in the Harvey-Bradley scale.
So Duffy, this is the type of study that pharma hates. 1 to 3, quote unquote, joints per day, right? What is it? This, that, right? So this is the problem as we get into the Schedule 3, is that we're never really going to be able to provide the research that some people still want, because of the difficulty in the standardization of the products, right? So we love this, but pharma hates this. Wouldn't you agree with that?
Yeah, absolutely. And, with botanical products or botanical medicines, I mean, that's always been one of the concerns or gripes from conventional medicine, is that they want to see these standardized numbers, and that they say, well, we don't even know how much. Not only do we know if it's 1 to 3 joints, but we don't even know the constituent profile of the medicines or the cannabis products or echinacea for that matter that an individual is using. And that's one reason that I am excited that we're bringing cannabis into the modern world and the new 21st century here with testing, right? Because we are absolutely separating ourselves from the old botanical medicine standards with having very rigorous testing for those products, standardized products, being able to measure out the exact constituent profile. Even though, that gives us that understanding and that baseline to work with, everybody's still different, right? And they're still using, and this is true in the pharmaceutical world as well, that we don't talk about a lot, is that everybody is different, and we are using different amounts of different pharmaceuticals based on that person's response. Many people self-titrate with pharmaceutical medications as well. So that's definitely a discussion, but as far as getting it across the line and getting other practitioners, conventional practitioners on board with the gold standards being studies, yeah, that is tough for some people. And that brings me to, this is an interesting one to talk about, because with this study, they're kind of trying to go towards standardized forms of medicine. They're using capsules with it, but this is a randomized, double-blind, placebo-controlled parallel group pilot study of cannabidiol-rich botanical extract in the symptomatic treatment of ulcerative colitis. They had 29 patients receiving CBD-rich whole plant extract compared to a control group of 31 patients receiving placebo. Again, these were capsules that they were taking, and it was a whole plant extract. But just even looking at the way that they were describing the potency of it, they did very little work to standardize or actually know what they were using. So it had up to 4.7% THC in it, and patients taking 200 milligrams CBD were receiving more than 9 milligrams of THC. So they were really kind of, if you're going to do a research project and study like this, right, take the time to standardize the medicine that you're providing. The other problem with this this is listen to this. CBD-rich botanical extract group were taking on average 1/3 fewer capsules than those on placebo due to adverse effects in the dose escalation phase. Dizziness, most common complaint. 12 patients were non-compliant in the CBD group versus 4 in the placebo group. And mean duration of exposure in the CBD group was 48 days compared to 61 days from the placebo group because of adverse effects. This is an education issue that they're having right here. They didn't take the time to talk about the escalation phase and going slow with the escalation phase. And if you're starting to feel side effects, you stop or back down on the dose. So they had many people that just left this study, which affected the significance of their results, and just based on education. So if, again, they would have done good education with these patients and found the appropriate dose for them while they were escalating up, I believe they could have kept these patients in this study, got good significant results. And I think that we see this a lot with many of patients that are coming into the medical cannabis world, and I definitely a concern with what you described with physicians that aren't managing these patients' cannabis use, that the worst thing you can do with a brand new patient, especially our senior patients that are really dealing with some significant issues and come to cannabis for the first time to get benefit out of it, the worst thing that could happen is they have that adverse event right off the bat, and they think that, oh no, this cannabis stuff isn't for me, all the stuff I heard about it is true, and it reinforces the stereotypes that they had when it could have been a life-changing medicine for them if we had the proper discussion with them and education up front, and again talked about dosing and again that escalation of dosing. And most people, if you go slow enough, they build a tolerance to these adverse events. And if you let them know it's something that is going to, they'll get used to, or it'll eventually go away, or they can titrate back on the dose and still get results, you'll keep them as a patient and again potentially change their lives.
Yeah, there's a fear of the intoxication effects of the THC, but as I tell my patients, you almost have to have a little bit floating between the ears in order to get any peripheral effects. So to me, it's kind of that tolerance to that feeling. Unfortunately, it's not your head in a bucket vomiting from chemotherapy, but actually a better wellness feeling from THC. So a lot of it's semantics and the expectation that you give to your patient. But I always tell my newbies that, hey, listen, if you don't have any effects yet, but you haven't felt anything between the ears, then don't fret. We just haven't gotten to that sweet spot yet.
Yeah, absolutely. And everybody's an individual, and you have to meet that patient where they are. So the results that they received, and even though they did a horrible job with their study setup, listen to this stuff here. So patient perceptions of disease activity measured by IBDQ and SGIC were significantly improved. Although small and not statistically significant, and I believe this is a study design problem, the improvements in rectal bleeding and endoscopy scores may be a promising marker of an anti-inflammatory effect. Circulatory inflammatory cytokines, interleukin-2, 6, TNF-alpha showed greater reductions in the treatment group, although they were not statistically significant. In the placebo group, 9 patients with adverse effects suggested worsening of the colitis, severe hemorrhagic diarrhea, colitis, or ulcerative colitis, compared to with only 2 that were receiving cannabis treatment. And then prior to treatment, no patients had a PGS severity score rated as normal, and approximately 75% of all scores were rated as either moderate or severe. After treatment, 77% rated disease severity as normal or mild, compared with 52% of the placebo group. So again, great potential there, even with a poorly designed study. So nutritional considerations on gut health. And again, I am a naturopathic doctor. I look at the whole patient. When I did patient certifications in office, I did a new patient visit like I was seeing any other patient, not just being there to get their medical cannabis card for them. And gut permeability, inflammatory response, the GI tract is so imperative to other chronic diseases and their health. Ultra-processed foods, I mean, we've got clinical studies on these. Ultra-processed foods are one of the things that are so tough on, again, permeability, inflammatory response, and that's why we see in the Western world, we see the incidence of IBD increasing. And one of the things that the biggest thing, I had one patient tell me one time, and I do the education around things that are inflammatory to the GI tract, and this patient came in with one of the 44-ounce thirst busters to the office visit full of Coca-Cola. So it's like, oh, totally cued in. If I can change that one thing right there, I mean, that could have a huge impact on this person's life. So we started having the conversation that sugar was inflammatory, and she said, what? Sugar's inflammatory? Oh my. And just one little piece of education like that has the ability to change people's lives. So even in those small visits that we're doing, providing those cannabis certifications, if you can connect with an individual and one thing at a time to move them forward into that healing space, again, it can have a big impact. Alcohol, again, has clinically been shown to increase permeability, enriched milk fat, gliadin, again, proteins in wheat, and then things that decrease permeability, inflammatory response, glutamine, main amino acid source for the GI tract, one thing that I definitely include when I'm treating patients that have barrier concerns, vitamin D, zinc, polyphenols, phenols such as quercetin, those complex carbohydrates that give the microbiome the food they need to turn them into these short-chain fatty acids. Again, very healthy and tighten up that gut permeability as well. Prebiotics, and then of course probiotic bacteria species. So I want to talk just a little bit in the time I have left about hyperemesis syndrome. This is something that, again, we're hearing a lot about, and there's a lot of journal articles on the topic as well. And the discussion is that it is something that is very much underdiagnosed, and maybe so, but I'm also concerned about overdiagnosis of CHS. I got a case study that you're going to love.
Yeah, Dr. Lynn Lassiter also will be covering that in her discussion about emergency.
So first reported in 2004 in 9 patients, and it was compared to an index report of psychogenic vomiting from 1996. This is a diagnosis of exclusion, so we really don't have any specific means or exams to diagnose it. Characterized by heavy cannabis use, cyclical vomiting that is ameliorated by warm showers, and does not respond well to conventional antiemetics.
How many doctors do you think know the warm shower correlation in the emergency department environment? I'm going to ask Dr. Lassiter the same question as well.
I think,
because that's key, right, Duffy? I mean, I have so many patients that come to me that said that the ER doctor told them that they have cannabis hyperemesis syndrome. And I said, did they ask you about a hot shower response? And when the patient says no, then I said, that doctor really didn't know of what they were asking you.
Yeah, I mean, I think that is getting around because that's really the only diagnostic criteria that they have, other than the cyclical vomiting on cannabis.
Well, it's the TRPV receptor crossover, so there's real science to it.
And we're seeing that capsaicin topicals are actually have been shown to be beneficial, that they're acting on those TRPV1. So that is an interesting topic for sure. So this was a review looking at 211 patients and showing the frequency percentage that these criteria were reported. So history of regular cannabis use for years, 74%, severe nausea and vomiting, 100%, vomiting that reoccurs in a cyclical pattern over months, 100%, resolution of symptoms after stopping use, 96.8%, reliable return of symptoms in weeks after resuming use. It was not calculated, or they weren't collecting all that data in the studies. Compulsive hot baths with symptom relief in 92%, male prominence 72%, abdominal pain 85%, at least weekly cannabis use 97%, history of daily use 76%, and age less than 50 at onset 100%. Now this is the type of study that's concerning me about this as well. So this was a screening questionnaire that they did, was posted online, 585 respondents. They ended up getting a reduced pool of 28 patients and 12 controls. Oh, no, pardon me. I jumped ahead. This is actually a great study that is being done by Russo, and they're looking at potential mutations in different enzymes and actors in the endocannabinoid system. And what they saw was that they did see specific mutations in this pool of patients with CHS. 12% odds ratio increased in COMT mutations, 5.8% odds ratio increase in TRPV1, and a 6.2 odds ratio increased with dopamine 2 receptor mutations, and a 8.4% odds ratio increase in ABCA1 mutations. So this is the type of studies that we need to be doing to really track down what's going on with CHS. This is the study, that's concerning me. I got a little over anxious there. This was Urban Public Hospital, and they were doing a survey. Anybody who reported smoking cannabis more than 20 days a month and that had of cyclical vomiting syndrome and also rated improvements with hot showers, they diagnosed with CHS, and that was 32.9% of their survey. So they extrapolated that there are 8.364 million near-daily cannabis users in the United States. So we have 2,130,000 to 3,330,000 people with CHS. So basically they're saying a third of the people that smoke cannabis daily have CHS. And I think these are the type of studies that are contributing to the hysteria word that was used. And this is a patient case report that came to my attention, and I thought it really outlined that. So we've got a 44-year-old woman with a history of severe abdominal pain, nausea, and vomiting. 6 years ago, she presents to her PCP with a worsening of her symptoms. Abdominal pain, 8 out of 10, severe nausea, vomiting times 2 days, fatigue, lightheadedness, dizziness, just a general feeling of unwellness and anxiety about her condition. She's had a history of heavy menstrual cycles in the past. Lab results showed mild anemia, again, decreased iron 27, decreased MCH, increased RDWs, and increased TIBCs. And her diagnosis from her primary care physician was that this was a psychosomatic condition that she was experiencing, and he referred her out to a psychiatrist for medication. So she never returned to that PCP. This individual had dealt with dietary concerns and keeping weight up her entire life, and she did have a naturopath that she saw for dietary guidance and nutritional support. And she also had her medical cannabis card that she used to stimulate appetite and for the GI symptoms that she dealt with. So 2 years later, she presents to the ER with a severe abdominal pain of 8 out of 10 and vomiting times 3 days. Blood work still showing mild anemia. They did do an abdominal CT scan, and they saw a 7-centimeter uterine fibroid. Urinalysis showed positive for cannabis, otherwise unremarkable. The treatment they gave her was IV fluids and IV Zofran, which she actually reported the IV Zofran was very helpful for her. And then they referred her to a gynecologist, and they told her to get counseling because cannabis was the cause of her vomiting. She goes to a gynecologist. They perform physical exams and a pap smear. The exams were reported as unremarkable, and no treatment was recommended. 1 year later, she presents to the ER again with severe abdominal pain and vomiting times 3 days. They do a blood draw and urinalysis is performed. They begin IV fluids. The patient was asked if she was using drugs. The patient responded no. She said that I didn't even think about cannabis as a drug. They were asking me like it was, illegal drugs and I was, abusing drugs. So I just said no, I didn't even think about it. The urinalysis returned positive for cannabis. The medical professionals came back in and told her that she lied about her drug use, and they discontinued the IV fluids before they were even finished, and they discharged her from the hospital with a diagnosis of cannabis hyperemesis syndrome.
Sounds like she could have just run into some bad queso a couple, 3 times over the 4-year period of time, Duffy.
Maybe so. Is that your?
No, I mean, gastroenteritis happens, and,
it's part of the DX, right?
bad queso,
Part
there's
of
an
the
inside
DDX.
joke to that.
So she returns to her naturopathic physician who provided IV fluids. Again, naturopaths in Arizona, we have a very large scope of practice. We can prescribe most pharmaceuticals. We can do minor surgery. We can do IVs and injections. And got nutritional support, mental emotional support, and she encouraged her to find a new gynecologist. Patient discontinued use of medical cannabis for over 9 months because she was concerned that she would not be treated again if she had another relapse or went to the hospital. And she was also starting to lose family support. Family was starting to buy in on the cannabis was potentially the cause of the condition, and she was, frankly, having some self-doubt around it as well. So she presents to a second gynecologist, having heavy cycles, now having appetite and weight gain loss since discontinuing cannabis. Blood work still showing slightly anemic. Abdominal scan, 7-centimeter uterine fibroid was still detected. The treatment plan from the gynecologist with birth control pills to manage the cycle. Surgical intervention was not necessary. She had had a bad reaction to birth control pills when she was younger, and that was not a path for her. She continued to see her naturopathic physician, who provided IV fluids and nutrition during vomiting episodes, and called out for some more blood work. And what she saw when she did the blood work was severe anemia, iron down to 7, hemoglobin down to 7.6, ferritin levels at 3, so dangerous levels of anemia. Ruled out the kidneys, ruled out a GI bleed, and she referred the patient to a hematologist and encouraged her to find a new gynecologist. The patient presents to the hematologist with severe anemia. They did weekly iron treatments initially, then monthly iron treatments times 18 months. And his suggestion was he'll keep her iron up, but it wasn't his job to find out why she wasn't maintaining iron levels. The fact that she failed to maintain those iron levels with the IV treatments ruled out GI absorption cause. So she presents to a third gynecologist. Blood work, still severe anemia, even though she'd been going through iron treatments for over a year. Abdominal scans, now 10-centimeter uterine fibroid, and several fibroids 6 centimeters in size. Treatment plan, immediate surgical intervention. Full hysterectomy at the Mayo Clinic. Recovery medications prescribed were 1,000 milligrams Tylenol, alternated with 600 milligrams ibuprofen every 3 hours, with 5 milligrams of oxycodone BID times 7 days. The patient reported that cannabis was very helpful in her recovery process. She reported using less than a third of the prescribed oxycodone, which was very beneficial for her because one thing she told me is that the bowel movements after a hysterectomy are very painful, and not having the oxycodone on hand was very, very helpful in her recovery process. Blood work, 1 month post-surgery, iron 98 within range, hemoglobin 12.8 within range, hematocrit 41.2 within range, ferritin 57 within range. Patient reports that nausea and vomiting is resolved even with her cannabis use. She reports severe back pain that she'd been dealing with for 2 years that just fell into the background of all the other symptoms that she was having. She just dealt with it, resolved as well. So these fibroids were pinching on nerves and causing postural issues that were concerning as well and causing symptoms. And the patient also added, she found that after she wasn't using cannabis for a long time and her symptoms were very debilitating, she started trying some other products to help out, and she found CBG to be very helpful for her. And she has now incorporated a CBG 1-to-1 THC gummy at night before bed. And she says that she can actually feel the difference between the CBG being in it and going to the gut, and actually could almost feel the healing process taking place along with it that she did not experience with just the THC product. So she reports better pain relief and healing effect in GI tract and bowel movements better, etc., and reports her mental, emotional balance is much better and has a sense of optimism towards health. So again, something for us to keep in mind. And I do think that there are people out there, I do believe that CHS is real. And I think there probably are different levels to CHS. I think one thing we don't talk about with heavy cannabis users, something I do hear is that, the wake and bake people, I just don't have an appetite in the day until I use cannabis. So again, cannabis is definitely involved in that appetite, in nausea issues and GI issues, but I think we need to be careful on our knee-jerk reactions with CHS. Thank you.
Awesome. And Duffy, it points out, because you mentioned CBG as an ultimate solution for this one gal. It points out the synergy between all of us and you guys to make sure that we continue to produce those high-quality multi-cannabinoid medicines, right? And I think what those of us in the audience are so fearful of is that legal adult use will overwhelm that right now. We're in such a critical point in time. My point about pharma is this: let them do their research over there, and then let us know what you find so that we can breed them into our whole plant product over here. I think there's room for both, right? We need those studies coming out of the pharma world, but we can't let them take away our whole plant medicine. And I think we all have fear of that. I don't think pharma will ever be a fan of flower. That's just my humble opinion, right? But we all know that flower is the chief means of relief for many, many of our patients. I think we may have a couple moments for questions, if there are any out in the audience, for either Dr. Troutt or Dr. Newton. Yeah, Mark. Hang on, Mike's coming to you.
I'm going to assume the answer is no. But has anybody looked into topical THC compounds for the ulcerative colitis, putting in RS oil suppositories up their rectum? And for that lady, how about using something like a marijuana oil into the cervix to help sedate the fibroids? And why didn't she see a gastroenterologist? Why didn't they rule out celiac disease?
And Duffy, speak to the GI world these days. Are they starting to accept cannabis as something that's legitimate in their world?
And, as you guys know this, most physicians are still concerned about cannabis being a Schedule I, and they're just not ready to wade into that conversation and discussion. And I think this individual, again, because of her experiences with conventional medicine, she was shied away from conventional physicians and just wasn't getting the direction that she needed. But as far as topical products, I think topicals are great. And this is one place with rectal concerns, ulcerative colitis, where I do think suppositories are a great form of the medicine. I think again, suppositories had a weird thing where everybody thought they had great bioavailability in the beginning, and then we found out they didn't have bioavailability, and then they left the shelves at the dispensaries. But for local conditions, I think suppositories are amazing. And I do, even though most dispensaries aren't carrying suppositories, I do educate my patients about how they can get a full spectrum oil and how they can find the molds and the other components that they need to make their own suppositories.
Yeah, it takes a pretty motivated patient to do that. Some do, but the topicals are tremendous, everybody. I tell all my patients, we didn't even talk about the topicals 5 or 6 years ago. Dispensary world wasn't making them yet, and we didn't have patients who were using them. But you just can't ignore that patient after patient after patient will come back to you and extol the positivity of the topicals, Duffy. It's just incredible. And I've been shocked by it, quite frankly, and that's why it's so ridiculous with the dose cap limits. In Ron's discussion this morning, he left out one phase. I like to say we've been in about 5 phases of medical cannabis in Florida: pre-flower, right, pre-telehealth, pre-edibles, pre-dose cap restrictions, right? To have a dose cap restriction on topicals, that just shows such a lack of understanding, okay, at the level of those who control the program, and it's so irritating. But the topicals are tremendous, and I think we've all found that out.
Regarding topicals, I'm a certified cannabis physician, and regarding topicals, most of my patients, 95% of my patients, don't know that there are patches that last for 72 hours, 3 days.
Absolutely, and I'm going to get on, and listen, we do have great topicals in Florida, but I want a 50 milligram CBD patch for 3 days. I want my patients to get 15 to 20 milligrams of CBD bypassing the liver every single day.
Exactly.
Unfortunately, the CBD patch in Florida right now for 3 days, and I love Move, they're a great company, 20 milligrams.
Exactly.
So to me, I want a 50.
But what I wanted to mention, is in the 4 years that I've been seeing patients, the most dramatic response I've seen are in patients with inflammatory bowel disease. I've seen a patient that was on 27 medications for her ulcerative colitis. And like all the other patients that I've seen with inflammatory bowel disease, they've told me they've been able to come off all of their Western medicine. And what's really interesting is that they tell me the only time they relapse is when they eat fast food.
Yeah, no, and listen, the reduction of medications, that's a general topic, that I just like to touch on briefly. I'm never either or guy, and I never present it as either or to patients. I'm a find that best balance guy, right? So cannabis becomes a very useful tool in the toolbox, or what I like to call it, the softest tipped arrow in my quiver, right? And nobody's ever died from my Nerf arrow, But nobody wants more pharma. People want less. But to give patients an expectation of getting off of everything, obviously can lead to some, obviously failures. So to me, I just like to present it to patients that we're going to educate you with another tool that can hopefully reduce your burden of the other stuff that you don't want to be on. And some patients do achieve that miracle of getting off all of their pharma. But I think to, and I know you know this, to put that expectation out can lead to a lot of patient expectation failure. But patients reduce on their own because it's their motivation. Not my motivation, not the motivation of the pain management guy or the GI guy. Each and every patient, because of their motivation, achieves their goals. We just teach them how to do it.
Yeah, I just wanted to add that, when you're looking at inflammatory bowel disease as well, we're focused on the inflammation, but also the endocannabinoid system is responsible for motility in the GI tract. And a lot of the patients that's dealing with this, alternating diarrhea, constipation, is also a dysfunction of the motility as well.
And I'm stunned by the scrutiny that we have in the cannabis world versus the GLP-1 world that has all these chronic gastroparesis patients and all that. We've seen some of them. And the lawsuits are starting to accumulate in that world, right? So it's really interesting, that the Ozempics and the Modernas and all that are seemingly causing some, permanent symptomatology in certain patients. But I saw an estimate the other day, estimated 9 to 10% of our population may be on, that type of medication within 5 to 10 years. That's scary to me. So, but, they don't get as much scrutiny as we do somehow. It's just, funny where the money flows. Listen, Gene, we're perfect right at noon, so I know you have announcements. Listen, I love being a moderator because I get to listen to all these people that are smarter than me, and I hope I bring up the questions even like during Duffy, that you guys have in your noggins, so it's a fun role. Thanks. Yeah. Sure. Right. Yeah. Sure. I learned that early on. I forged a nice relationship with the pain management guys in my zone. I get referrals from them every day. They know I have no desire to take their patients away. I want to find that best balance so that their morphine equivalents get half. That's all. Oh, I know. No, they're fearful. It's always fun. Carlos always Sure. Me too. They inspire me.
97, 98 years old.
Right.
That have never used cannabis in their life.
Right.
You get them on the program.
Right.
Next thing you know, they come back. They're calling me a month later, 2 months later.
Greatest thing in
Oh
the
my
world.
God, I'm off this, I'm off this, I'm off that. I'm sure as you've got so many patients out there, opiates.
So how do you do your follow-ups? Do you schedule specific follow-ups after you see the patients?
And my older patients, yes, I like to see them back.
See, we have a free follow-up policy in my office. Once we see them,
Right.
for the next 210 days,
Right.
they're welcome to come back as many times as they need
That's
to.
fabulous.
They tend not to have to need more than 1 or 2 visits.
right.
But we love, listen, they laugh at me. I tell the patients, I want to pay you
Right.
to come back for that second visit because that's the only way that I can get better for the next patient.
And you know what?
But you have to have our attitude
Without a
and
doubt.
not just be a card generator.
No, without a doubt. That's exactly it.
That's why I love this gal's question, earlier today, because she's calling out the industry for what we all know we all want to try to avoid.
Without a doubt. So many of these critics, they don't want to do it. Look at that. They're having to
Yeah.
come in every 3 days. Here's
Yeah.
your another
No,
RX
no.
120 oxycontin.
No, for sure, and that's why the race to the bottom of what we do is so dangerous because you can't undervalue what we do. If you price it too low, and then you can't staff it.
Right.
It's just a neat card generator. I tell everybody, and Patty will tell you, my source of happiness is the fact that I've never expanded. I don't want those 15 centers trying to staff them and run all over the place. No, that's not
I'm in one
medicine.
place.
That's business.
I'm in one place.
Good seeing you.
Man.
No, listen, Patty wants me to retire 100%. As I tell her if I did that, then, I would, melt away. Everybody says, when are you going to retire? I said, I'm not 100%.
So I sold my practice 7 years ago.
Sure.
When I sold it, I had
Right.
we were at 7,000 patients.
Sure.
I had 15 employees. I had
Right.
2 nurse practitioners, a PA. I was going on my fucking mind.
Right.
The best thing I ever did was sell the practice.
Sure.
And just,
Right.
it's cannabis. But what happens is, if you completely retire, you start to feel irrelevant. You become irrelevant.
Of course.
And in your head, you think, what the fuck am I doing?
I could never retire.
Yeah, but.
All right.
Raise the supplement. Enjoy lunch.
That's from the powerful one, not from the, I can't tell, because there's 2 things. The bibliography page, I think it's the fees one.
Hey, Tim. Put us up one. Put us up.
So we got that. So, I don't have my glasses, I apologize. Take this one, go.
the
agree
handbook.
on the
Okay.
handheld, yes.
And they want us to stay up there,
Correct.
like,
You have 30
give your
seconds
talk
to-
and then